rheumatic fever, if they give this class, no problem. Rheumatic fever will be informative for you. Okay, now dermatomyositis. Dermatomyositis is one of the connective tissue disorder, including this group. It means you already understand that there are problems some connective tissue, and what it means. Dermatomyositis. Derma, skin. Okay, let's wait 2 minutes because your group mate joining. Okay, 2 minutes, we'll wait.
Hello, others. Hello, other students.
Yeah, I already know them. It's just
I'm present.
okay. Okay, let's start. In dermatomyositis, as I said, there is connective tissue disorder. Now there will be mainly two changes of connective tissue. It means derma, skin. It means skin change, and myos, it's muscle. Itis, as usual, inflammation. It means inflamed changes of skin and muscle, students. Dermatomyositis, chronic autoimmune inflamed disease with damaging of skin or and muscles. It means sometimes there might be changes. Okay, I will open first. Yeah, sometimes there might be skin damaging with muscle damaging. Sometimes might be just muscle damaging. Due to this, we can classify dermatomyositis for big two types. First type is real dermatomyositis, where affected skin and muscles. And second type, no, we have three types. First, skin and muscles. It's called dermatomyositis. Second, when affected just muscles, it's called polymyositis. And third type, when affected just skin without muscle inflamed, without muscle involvement, it means atypical amyopathic dermatomyositis. Again, I repeat for students, classical dermatomyositis, polymyositis, atypical or amyopathic dermatomyositis. Three big type of disease. This is mainly classification. And other classification I want to show this slides. Classificate like adult dermatomyositis and juvenile dermatomyositis. And classically and clinically, juvenile dermatomyositis. About adult, I already said classic dermatomyositis. Clinical amyopathic, I already said, and sometimes dermatomyositis might be associated with malignancy, and sometimes, of course, with other connective tissue disorder, for example, mixed disorder or overlap when it's associated with systemic scleroderma. Okay. Epidemiology effect 9% per million population, and it's not so often disease. It's rare, I guess, than SLE, then systemic scleroderma. More affected adult in 50 years old, children if affected 5 to 10 years, mainly this year's affected, till 60 years old, it's affected juvenile form. I hope you remember about this. And as usual, more affected women than men, as rule. Toya have some problems. He again and again leave session and again ask to join. Okay.
Ma'am, he has some
ATO,
internet problems. He has unstable network
yes,
connection.
because he third time leave and again ask to join. Etiology, as usual, no cause. We know that rheumatological disease, there is no cause. Today I didn't see students mean. Where's mean?
Here, ma'am.
Where's mean?
Present, ma'am.
Means yeah. Можете это уменьшить, да? Или это каналаться очко, очкам. Может, открыть, если жарко. Нет, чуть-чуть открыть. И она затянула снаружи, там 300. Okay. Etiology, unknown cause. Etiology, unknown cause, students, but as usual, we have genetic predisposition, human leukocyte antigen responsible for this disease, and we have responsible gene HLA-DR3, HLA-DR5, and HLA-DR7. This gene is shaped strongly with dermatomyositis. Internal factors. About external trigger factors, as usually there is same trigger factors like smoking, cold, stress, trauma, malignancy, secondary disease, and a big role in this disease. Doctor think we should give for viral infection, because why viral infection? Because when doctors do biopsy of muscles, because for diagnosis of dermatomyositis, that biopsy is gold standard. This biopsy we can find necrosis and inflammation of the muscles. And doctor, when do biopsy of muscle, they often found they often found a viral infection in muscles. Which viral? Epstein-Barr viral infection again, mainly. And what happens when there will be persistent circulation of viral infection? For example, yes, because big percentage, I said, for viral infection will give you pathophysiology. There will be humoral attack to muscle couplers and small arterioles. Why? Because they was affected by this type of viral infection. And of course, when there will be when endothelium part of capillaries and arterioles was affected by viral infection, there will be humoral attack to this endothelium part, because they found that there is changed endothelium part, and they should stop this process. And again, start same process. There will be deposition of the inflamed cells, which increase destroying of capillaries. It means, yeah, we say that there are problem with muscles and skin, but muscles and skin rich with small arterioles. And of course, when we say about inflammation of muscle and skin, first of all, we mean inflammation of small capillaries and arterioles, students. Later, when there will be persistent inflammation of muscle and skin, not only about muscle here, also about skin, dermatomyositis. there will be a microinfarction of skin and muscles, chronic inflamed process. Later, this microinfarction become to big infarction, and later it become to necrosis, and yeah, there will be changed structure of normal structure will be changed, and there will be big change of skin and muscles. First partly, later big area of these tissues become to abnormalities. Okay, some seconds like this. Now, what about other organs? Yeah, as usual, there will be change of other organs, like in SLE. If you remember, of course, they also start from skin, but they will be internal organs involving joints. In dermatomyositis, same situation, but mainly symptoms start from skin and muscle. It's not so dangerous like SLE. It's a little bit soft than SLE. Okay, now let's start about clinical manifestation. Clinical manifestation about skin first. Skin findings start 2-3 months before muscle weakness. If it's real classical dermatomyositis, if just cutaneous form, amyopathic, atypical form, they will be, of course, only skin features. Now, about classical, I said, first skinning off, there will be specific change, and later 2-3 months start symptoms of muscle changes. What including skin changes? There will be erythematosus patch and plaques with or without scale. Its primary lesion. There might be poikiloderma. They might be frequently involve scalp, anterior or posterior neck, photoexposed areas, and extremities. Except this, okay, this is in this picture there is alopecia, but it's like scaly scalp alopecia, like one line, not diffuse. Initially there was diffuse, there is scaly scalp, that's why you can differentiate between these two diseases. Next change of skin, very specific change, it's called heliotrope rash. This change very often will be a big sign of the dermatomyositis. First, there will be periorbital symmetric, sometimes with, sometimes without edema, purple reddish color rashes like this. It is heliotrope rash. In this patient, we found present edema. As I say, there is a reddish purple color. Which disease it look like? Some kidney disease, for example, if there will be edema, yeah, it little bit confused doctor. But what we should do, check analysis and then understand that there is not kidney disease, there is skin disease. Heliotrope rash. Next is Gatron papules. These papules will be located on the dorsal hands, MCP, DIP, PIP. This is Gatron papules. Gatron papules also will be, papules always include inside some little bit fluid, you know about this. And nephrotelangiectasia will be here also. Next, it's Gatron signs. Gatron signs, it's different than Gatron papules. 1 second, I will show if I have, but I have not, no problem. Gatron papules in dorsal part of MCP, PIP, DIP. Gatron sign, they will be symmetrical macular erythema, and mainly they will be located in elbow, knee, like area where is will be flexion of the big joints. And You should understand catron site different, catron papules different. Okay, next there will be a tendon streaking. There will be a liner erythema along extensor tendons of hand and of feet. Next change, nail foot problems, nail foot changes. Already I showed this picture. They might be capillary telangiectasia in parts or capillary loop dropout. And next change, V sign. This is also, you can tell that it is V sign. This area called V zone. V sign, V sign, it's macular erythema and poikiloderma of upper back and shoulder. It means you can tell that V zone, it locates in this area and a little bit in shoulder area. Okay, and paniculitis, you can find paniculitis like this in patients with dermatomyositis. And Holster sign, it's page of plaques. Next change, it's malar rash. If you remember, 1 second, I will show you this patient. Look here, a little bit. No, it's not malar. Purple, red color with edema here. Here without edema, it is heliotrope rash symptom. Rash, it's different. If you remember, I said there will be a erythematosus rash on cheeks. It looks like SLE, but don't involve this area, dorsal part of nose, and okay, his area also don't involve. Next specific change in dermatomyositis, it's all about skin change, students. Next change is about hands. There will be mechanic hands due to hyperkeratosis of the palmar and lateral surface of fingers. Patient hands look like mechanical hands. It will be very hard. He can't flex his hands. Look like worker hands. You also can tell worker hands, yes. And these changes, mechanics hands, strong associated with intestinal lung disease. And calcinosis. Calcinosis, yeah. For dermatomyositis, specific presence of calcinosis students. We found calcinosis everywhere, but mainly we will find calcinosis on the skin in a region where was trauma. Oh, 1 second. Trauma, yes, in area where was trauma mainly.
In burning also, ma'am.
Yeah.
In burning also, ma'am.
In burning, yeah, it's also type of trauma. Yes, why not? Might be, yeah. By X-ray, this trauma will be visible, and if you want to be sure, you can check by X-ray to exclude its nodules or calcinosis, but even without X-ray, I guess you can differentiate its nodules, tophus, or calcium deposition. It is derma changes, just skin change. Now about muscle change, students. What happened with muscles? Muscles, if it's classical dermatomyositis, after 3 months, I already said about this, start 2-3 months, start muscle changes. Patient start notice there is weakness of muscle weakness. It will be hard to raising up his hand over the head. arms over the head, rising from a sitting position. It will be hard to climb into stairs. It will be hard to climb to the bus. It will be hard to sometimes walking. And if there is bus symptom, if patient can't climb to bus, it will be bus symptom. And also there is one symptom, it's called pillow symptoms. Patient, when he lie down, he can't up his head from pillow symptoms. It means muscles weakness will be very strongly. But look at here, don't forget one thing, mainly affect proximal muscle weakness. For example, distal this part, proximal this part. For example, patient can't up his hand like this. He can distal, but this it will be hard. He can't climb because hip can't. Hip muscle can't up his foot. That's why don't forget to say that there is proximal muscle weakness present in patient with dermatomyositis. Pillow symptom, bus symptom. Patient also can't brush later his hair. And yes, this is mainly symptoms. About which disease look like dermatomyositis disease, it is myasthenia gravis. If you remember, it's neurological disorder where will be problem with cholinesterase receptors. Patient also feel muscle weakness, but I'm not sure that there is proximal muscle weakness. In myasthenia gravis, I don't remember, but in myasthenia gravis, if I'm right, there is not proximal, there's distal maybe, I'm not sure. You will read about this and same in practical part. Okay, 1 second, I'll close my window, it's cold. Okay, and this is mainly symptoms. Now about extra symptom, extra cutaneous findings about proximal muscle weakness. We already said these symptoms, these findings, clinical findings, very often we can find in patient with dermatomyositis. Okay, dysphagia or dysphonia. Why? Because here we also have muscles, and due to the weakness of these muscles here, the patient can't normally properly eat food. Dysphagia and dysphonia, the problem with sound. He can't properly pronunciate sound. Dysphonia, it's called. Pulmonary disease, we already know, strongly associated with 1 second. So I show you. Where was this slide? Yeah, with mechanic hands, I said. Yes, with mechanic hands. Synovitis, inflammation of the synovial membrane with change of the synovial fluid. When we say synovitis, always we should understand the really problem with synovial fluid also. Raynaud's phenomenon and heart disease. Okay, now Raynaud's phenomenon, what is it? Raynaud's phenomenon or Raynaud's syndrome, same phenomenon, syndrome, it's same in this disease. Raynaud's syndrome is syndrome which is characterized by the rapidly vasoconstriction of small vessels due to stress, cold, smoking, like this. They will be due to rapidly vasoconstriction. Patient feel cold hands and there will be change color of hands from white to blue to red. Because white ischemic stage, blue because there will be less oxygen, and red when oxygen again restart. Raynaud's phenomenon sometimes might be first syndrome of the disease. Raynaud's phenomenon as syndrome might be in different type of disease. In SLE also sometimes might be dermatomyositis more often, and for systemic scleroderma it's 100% specific syndrome. That's why when you found in patient Raynaud's syndrome, don't be sure that it is systemic scleroderma. Sometimes it might be dermatomyositis or SLE also. Okay, about this, we already said. Classification done. Okay, diagnostic criteria. No, let's talk about lab test and then come back for lab for diagnostic criteria. Okay, diagnosis. First lab test. Usual routine test. Usual routine test mean yes. Oh, sorry. CBC, common blood analysis, common urine. Yes, inflammation biomarkers, and again some specific lab tests like antibody or something else. Yes, in this disease there will be something other specific test. There will be increased muscle enzymes. I hope you remember in the beginning I said there will be microinfarction and necrosis of muscles, and due to this necrosis, do you remember, students, in myocardial infarction, do you pass cardio subject? Did you pass cardio, students?
Yes, ma'am.
Great. Tabinda only pass, yes. And when there will be myocardial infarction, which enzymes increase Tabinda? Do you remember or forgot? I guess you forgot.
Cardiac troponins, ma'am.
Traditional
Troponin markers, ma'am. Cardiac troponin.
Is troponin T and troponin I. It means in our body, if there will be something destroying something, come to infarction or necrosis, always produce some specific enzymes. Like this in cardiology, in rheumatology, in dermatomyositis, when will be necrosis of muscle, infarction or necrosis, will be increased creatinine phosphate kinase, CPK. Creatinine phosphate kinase in 65% very specific test. It's high specificity, and aldolase in 40%, and lactate dehydrogenase finally. Lactate dehydrogenase, students, might be increased in other type of disease also, when problem also is liver. I hope you know, but it's also have specificity. 1 second. It's also have specificity for the muscle problems, muscle necrosis. Now you check routine test, you check some muscles enzymes, but again you should check antibodies to be sure, to be proved. We will check anti-nuclear again, so famous, so useful. In 40% it will be positive. And for dermatomyositis, except the antinuclear, you can check more higher specificity, have anti-GO test and 155-A test. These two tests more specific, antibody test more specific for dermatomyositis. Now you already know, students, for each disease we have different type of antibody. Of course, we have some usual antibodies. You already noticed that anti-nuclear, anti-nitrohistoplasmic, rheumatoid factor, we always love and like check. But sometimes they have high specificity, sometimes low. For example, anti-nuclear, you already know more high specificity for SLE, but always we check this test. And urine elevated 24-hour creatinine excretion test. It should be more than 200 mg in 24 hours. It's also useful. And always we check imaging test. Pulmonary test we will check because before you already read that they will be very often intestinal lung disease, capacity we will check. Electrocardiograms, esophageal manometry because they will be dysphagia, if you remember. Colonoscopy sometimes because muscles is affected. Sometimes the patient also complain to a problem with the colons function. MRI or ultrasounds of muscles. Why not? If they will be inflamed or necrosis. Sometimes if we have not biopsy, can't do biopsy, you can check by MRI or ultrasound. Chest X-ray necessary always. Barium swallow test again for dysphagia and colonoscopy, and electromyogram. EMG, it's a great test for dermatomyositis. Mainly for form when we talk about muscle and skin change, because if it is atypical amyopathic, electromyograms will be normal because muscle will be normal, just skin change. 1 second. Okay, great. Electromyogram for muscle change. About skin, if you think about atypical amyopathic dermatomyositis, when affect only skin, you should check biopsy of skin. Also, you can find necrosis, infection of skin. Necrosis and infection, remember, because in systemic scleroderma, in biopsy of skin, you will find fibrosis of skin. There will be different situation. Muscle biopsy, what you can find by muscle biopsy? There will be perivascular and intravascular inflammatory infiltrates with muscle fiber degeneration, and necrosis. And of course, criteria. Criteria always help students. I hope you already understand that criteria might include symptoms, sometimes clinical findings, sometimes might include imaging tests, sometimes lab tests. It's a combination of the mainly moments of each disease. Remember about this. For each disease, I already said criteria, except gouty arthritis. If you notice, gouty arthritis criteria we have, but I didn't give. We will discuss about criteria of gouty arthritis and practical part. Diagnostic criteria of dermatomyositis, symmetrical muscle weakness. It might be absent if it's typical form, you remember. Muscle biopsy, fibrosis, necrosis, inflammatory exudate might be absent if it's atypical. Elevated muscle enzymes, creatine phosphate kinase, and the last lactate dehydrogenase might be normal if it's typical again. EMG triad, electromyogram striate, remember there will be small polyphasic action potentials, positive sharp waves, big, and there will be high frequency repetitive discharge. And this MG also might be negative. Normal, it means if it is atypical, yeah? All first criteria will be positive only for classical dermatomyositis or polymyositis, where will be absent symptoms of skin changes. And final fifth, it's about skin change, cutaneous finding. There will be heliotrope rash, big symptoms of skin change, and scaly dermatitis. This is change of skin. 5 diagnostic criteria. First 4, it's about muscle. If this is atypical form, of course, you will find only one criteria. If it is polymyositis without skin change, you will find first 4. If classical, 5-fold. Okay, how we will treat patient? As usual, okay, symptomatic or non-steroid anti-inflammatory drug. If patient complain to pain, some inflaming the muscle pain also sometimes will be big pain for patient. Give big pain for patient. In this situation, we will recommend nimesulide. Yes, always we know that nimesulide is now more good. It's better than ketanol, or better than diclofenac, ibuprofen. It's more helpful for decrease relief pain. And next, as usual, we will give corticosteroid. And I always say it 1 mg per kg. Okay, no problem that there's 0.5, no problem. Usually we'll give 1 mg. In patients with dermatomyositis, we can increase to 1.5 mg, 1 mg per kg, not effective. We'll give while muscle enzymes will be normal. But maximal dose 60, again, I repeat. And again, DMARDs, we know always DMARDs, third group, which we always recommend, best combined with azathioprine, 2 to 3 mg per kg per day. Okay, this is mainly treatment. Other will be symptomatical, some vitamins for muscles, maybe of some PPI inhibitors, symptomatical for dysphagia, some bronchodilatators if there will be some intestinal lung disease. Right, this symptomatical treatment always in patients with rheumatological disease. You will, okay, this, for example, antimalarial hydrochloroquine, mycophenolate mofetil should be in previous slide. This group of drug also you will recommend if azathioprine not effective, no problems. Next demand is mycophenolate mofetil. Sometimes we can recommend also antimalarial drugs. Before in SLU you already saw that hydrochloroquine also useful. And it's necessary also to avoid SAM. Immunoglobulins we will recommend for patients sometimes. And what also, some physiotherapy also we will recommend. Exercise, it's necessary to help patient to be protect of the complication of dermatomyositis, but physiotherapy never will recommend in acute phase when high inflammation biomarkers. Remember about these students. When inflamed marker high, always we will recommend rest. About this you should know, not only about rheumatology, always in all disease. Okay, it is about dermatomyositis. I guess all students today. I say dermatomyositis, not so long, not so big topics. We discuss, usually it's fast. Okay. Who was joining later, I already said Monday we'll talk about systemic scleroderma, osteoarthritis, and maybe rheumatic fever, maybe. I'm not sure, but maybe. Monday, you said that at 12 o'clock we have class, but let's start at 2:30, I guess, because I should be on meeting at 12. in office. That's why at 2:30, please, students, leaders, remember, okay? Don't disturb me on Monday at 12 o'clock. Leaders, do you listen to me? Are you listening to me?
Yes, ma'am.
Okay,
Yes,
great.
Yes, ma'am.
Guess 2:30, I will be at home and can join by Zoom. 2 topics, maybe 3, depend from the time. And so